I'm going to tell you a story about type 2 allergic immune responses in COVID-19, and this is predominantly the work of Ali Donlan, who is a graduate student in our lab and is now a postdoc at the Hutch in Seattle. And what Ali did was to look at the first 180 patients at the University of Virginia Hospital with COVID-19 and did a cytokine multiplex analysis of them. And what each row is showing you is an individual patient, and then each column is a different cytokine with like almost 50 different cytokines measured. And it looks like complete chaos, frankly, and that is kind of a reflection of the immune response against COVID-19. Tremendous inflammation, activation of multiple arms of the immune system. But there's a favorite quote of mine from Louis Pasteur, which is like the chance favors the prepared mind. And Ali Donlan was prepared to look at this data as a graduate student because she knew that IL-13 and type 2 immunity in general in the lung was damaging in asthma. And so in any case, like a type 2 or allergic immune response is a bad thing in the lungs. And so what Ali did was she looked specifically at the column that had IL-13, and you may be able to appreciate that on our far left, the dark green are patients that were on ventilators or ended up on ventilators, and the light green are patients who left the hospital without ever receiving mechanical ventilation. And a darker color means higher levels of IL-13. And so there was a correlation of a lot of IL-13 with the propensity to end up on a ventilator. And in fact, when she looked at this data in detail, in blue, patients that had the highest amount of IL-13 on the day of admission were most likely to end up on a mechanical ventilator, so 50% compared to 20% of patients in the lowest quartile. And so again, this thought that IL-13 could actually be damaging the lungs in COVID-19. But of course, like the problem with like studying or making observations in humans is you don't know the chicken or the egg. So is IL-13 a good or a bad thing with this disease? Certainly, it's higher levels of IL-13 are associated with a worse outcome. And so Ali developed the mouse model of COVID-19 in the BSL-3 lab and infected mice on day 0, and then could follow disease out to day 5. And in fact, she found that mice that were infected with SARS-CoV-2, which are the blue columns, had a type 2 immune response compared to uninfected mice. And so it appeared like that this mouse model was reflecting what we were seeing in humans is a allergic or type 2 immune response. And so it begged the question was that if you neutralize that response, can you protect a mouse from SARS-CoV-2 infection? And so Ali administered antibodies against IL-13 on day 0 of infection, then on day 2, and then followed the survival of the mice. And this is followed in 2 ways. On your left, we're looking at how sick the mice appear. This is weight loss, ruffled fur, their movement in the cage. And in yellow is mice that had IL-13 neutralized. And you can see that they had a lower or a better clinical score out to day 7 than mice that received an irrelevant antibody control. And then on your right, we're looking at survival of the mice. And again, like the mice that received anti-IL-13 had a higher survival. So this supported the fact that IL-13, in fact, was a bad thing in COVID-19. And this was independent of the amount of virus in the lungs. And so when viral plaque assays were done, there was the same amount of virus in the lungs, whether you neutralized IL-13 or not, really suggesting that this effect was via the immune system and not by protecting from the virus itself. And in fact, when IL-13 was neutralized, again in yellow, there was lower numbers of immune cells in the lungs. Again, what one would expect if IL-13 is promoting inflammation in the lungs. So this was all well and good, but we couldn't understand really how is IL-13 acting to worsen disease. And so with Chelsea Marie, we did RNA sequencing of the lungs and looked to see like what genes were most different in the lungs of a mouse where IL-13 had been neutralized versus not after infection. And there was one gene called hyaluronan synthase 1, and that was the most differentially expressed gene. And so HAS1 or hyaluronan synthase 1 was inhibited by IL-13. And we can see that on your right by then measuring hyaluronan in the lungs, in the parenchyma, in the blood vessels or the airways of the lungs. And in every case, the light blue was the hyaluronan levels upon neutralization of IL-13. And so this suggested like a novel mechanism by which type 2 immunity can be damaging the lungs through the production of this polysaccharide called hyaluronan. It can bind water, and it's almost like flypaper for immune cells as far as having immune cells recruited and then staying in the lungs and contributing to inflammation. And so again, like IL-13 neutralization decreased the amount of hyaluronan stained in green on the right compared to an irrelevant antibody. And you could actually directly administer IL-13 to the lungs in the absence of SARS-CoV-2 and induce hyaluronan synthesis, proving that this is a novel type 2 immune response. And then working with patients who had, or autopsies of patients who had died of COVID-19, we could see in green again, like that the patients with COVID-19 had higher levels of hyaluronan than patients that died from other causes. So then just to complete this story, if you neutralize a receptor for hyaluronan on white blood cells, a CD44, that is lower with neutralization of IL-13. And you can actually use antibodies against CD44, and you get a modest level of protection. So sort of evidence like that IL-13 could be acting via hyaluronan to worsen COVID-19. So just to summarize where I am right now is like, so I've shown you that IL-13 elevations were higher in patients that ultimately required mechanical ventilation, that neutralization in a mouse model protected from disease and mortality, and that the hyaluronan receptor CD44, if you neutralize that, you could also protect a mouse. And so can we utilize this information in people? And I'll show you a retrospective analysis and a clinical trial. So there is a drug that blocks IL-13 and IL-4, and that's called Dupixent or dupilumab. It binds the IL-4 receptor alpha. And so we asked the question, are patients that are on this drug at the time that they catch COVID-19, so to speak, are they protected compared to propensity-matched control subjects who are not on Dupixent? And in fact, that was the case. And so going into an electronic medical record database, in purple are 937 patients who were on dupilumab when they contracted COVID-19, and in light blue are matched controls that were not on dupilumab. And you can see that the survival was slightly but significantly greater with patients on dupilumab. So some retrospective analysis suggesting that this could be a therapeutic avenue. And based on the safety record of dupilumab, we received IND approval from FDA to test it in patients at the University of Virginia with COVID-19. And so we administered the drug the same way you would to someone with asthma, which is it's injected, and this has a half-life of about 2 weeks, and so it's administered every 2 weeks. And so on the day of admission, patients were randomized either to receive dupilumab or placebo. And if they were still in the hospital on day 14 or day 28, they received additional doses. And what we found at day 60, and this is the work of Jen Sasson, who's now on faculty at UVA, that patients that received dupilumab, or the blue line, had a lower probability, not statistically significant, but a lower probability of ending up in the intensive care unit. And then as a secondary, then we also saw changes in downstream cytokines downstream of IL-13, evidence that the drug was active. And then As a secondary outcome, not the primary outcome, we saw a reduced mortality in patients at day 60 who are on dupilumab. And so the blue line is dupilumab. Survival was about 90% compared to 80% in the placebo group. So what I've shown you now is that we can go into humans with the clinical data now, look both retrospectively and then going forward with a randomized controlled trial, supportive evidence that blocking this pathway could be beneficial. So, and we all heard a lot about long haul COVID-19 or post-acute sequelae of COVID-19. And so Jen Sasson continued the study out to 1 year of age and 1 year after randomization, and discovered two things. Number one, the dupilumab patients again are in blue, and you can see that the survival difference between them and the placebo subjects widens by day 365. And so essentially more mortality continuing out to 1 year in the placebo patients versus the dupilumab. And then importantly, pulmonary function was preserved in more patients that received dupilumab than placebo. And again, like the dupilumab for most patients is only administered once on the day of hospitalization. So it suggests that there's a potential that by inhibiting IL-13 induced inflammation very early, you can provide long-term benefit to patients. And so that's all the data that we have. And this will be like the very last slide. Where do we go from here? Well, we're still continuing to work in the mouse model to understand how IL-13 and potentially hyaluronan is contributing to the pathogenesis of COVID-19. And we are planning for a larger multi-site study of dupilumab's use to see if we can validate this very, very small randomized controlled trial that we did at UVA. So again, so thank you for your attention. And Scott.